Hi, my name is Taylor Culmone, and this is my Doctorate of Nursing Practice project, Improving Referral Rates and Identifying Barriers for Patients with Alcohol Use Disorder. My committee members are my chair, Dr. Ashton Lindsay, my second reader, Dr. Siri Dallaire, and my community member, Mary Rom. The uncertainty and often instability of an alcohol use disorder diagnosis creates difficulty for patients to make timely follow-up appointments or to be compliant with their discharge care instructions. Patients suffering from alcohol use disorder often overutilize the emergency department and its resources because they are unable to manage their own care at home. Historically, these referrals are only completed at the patient's request. The standardization of screening and interventional tools helps reveal that the evidence supports a multifactorial practice change, encouraging the implementation of the audit and SPIRT in emergency departments to increase rates of referral to treatment while reducing pre-existing barriers to referral through a multi-step process. Several studies in the literature have noted that the ED is an opportune place to recognize, screen, and intervene patients with alcohol use disorder due to its purpose within the healthcare system being a critical access point for patients from all walks of life. Through this project, patients received equitable and just treatment that goes beyond current stigma. Providers were focusing more on referrals and treatment's goals, rather than only on the management of behavior and withdrawal symptoms. Bedside nurses felt more empowered to work with alcohol use disorder patients after being properly educated on how to care for them, and the positive outcomes of the project included increased referrals, recovery for patients, increased quality of care, and decreased stigma and recidivism. The aims of this project are to create and implement a standardized screening and referral process for patients with alcohol use disorder, to increase treatment referrals for patients with alcohol use disorder, and to identify nursing barriers to making referrals for the alcohol use disorder population. In the literature review of this project, the literature revealed several themes, the first being screening for alcohol use. The literature demonstrated that emergency medical providers are positioned to mitigate the detriments of alcohol use and improve patient outcomes, as well as that the providers lack a universal tool or formal process for referral. This is possible through the use of the audit screen and the SPIRT method of referral. The second theme is collaboration. Collaboration in healthcare is born out of necessity to close practice gaps and deliver quality care. Cooperative relationships in the hospital setting allow for co-occurring medical and substance use treatment while prioritizing the patient. Collaboration with transitional services creates access and streamlines referrals. Nurse-patient collaboration allows the patient to constructively discuss their drinking behaviors in an environment that fosters dialogue and understanding. The third theme is compliance. Compliance from the patient, provider, and leadership is imperative to successful outcomes in referrals. Patients with no interest in sobriety will not adhere to treatment regimens, remain in voluntary detoxification programs, or attend referral appointments. Barriers like lack of knowledge, skepticism, and time reduce provider compliance with making referrals. Theme 4 was resource availability. Alcohol use disorder patients take up resources given their high rates of malingering and recidivism. Instituting change requires both financial and human resources. The audit and SPIRT are more cost-effective and improve patient outcomes compared to current practice. And the last theme is barriers to referral. Nurse-reported barriers to referral are lack of education, inadequate training, stigmatized populations, and competing care priorities. The time it takes to complete the audit and SPIRT is less than or equal to the time spent on recidivist visits or patient behaviors. Miscellaneous barriers included language barriers, altered mental status, and the necessity of withdrawal sedation. The framework used to model the design of this project is the Knowledge to Action framework, which informs the selection and implementation of new evidence-based practice in the clinical setting. This framework integrates knowledge creation and implementation in a top-down fashion, almost like a funnel, starting with a broad sense of the topic and working through its logistics in the system. Steps of the KTA cycle applied to this project are 1. There is a lack of referrals and treatment for the alcohol use disorder population. 2. Referrals to the Community Transitional Care Center were reviewed for successes and failures. 3. Knowledge of the audit and SPURT tools is functionally implicated in overcoming each barrier to use. 4. Intervention-specific categories were tailored to audit risk scores. 5. Results were monitored by referral metrics and a questionnaire regarding nurse-perceived barriers. 6. The audit and SPURT improved referral rates and reduced barriers. And 7. This process can be adopted into practice and policy and be built into an electronic charting system. The methodology of this project is based on the Project Management Information Systems Project Management Body of Knowledge, which follows a waterfall-style methodology where universal standard practices are planned fully and then executed through stages. The audit was used to screen patients into a score-based category. Based on that category, the nurse provided a score-based motivational interview and educational intervention surrounding the risk level of drinking. They discussed the benefits and availability of treatment options, and they offered a referral. The day shift nurses called the referral center and brought a recovery coach on site to perform the patient's intake, while night shift nurses input the patient information into the referral center website so the patient received a next day phone call for their intake. After this was complete, nurses who performed the referral completed an assessment packet, and the referral data was compiled into the data collection sheet. This is what was included in the assessment packet, starting with the audit screening that was performed with the patient. The middle portion is the score-based motivational interview that included a prompt for nurses to follow when educating patients on their alcohol use risk level. And the third portion is the questionnaire nurses filled out regarding whether a referral was made, why, and the perceived barriers that would have prevented them from making the referral in the first place. This is the data collection tool where the assessment packet data was compiled upon completion. The setting for this project was an emergency department located in the northeastern region of the United States. The surrounding community has a significant homeless population, most of whom enter the ED for alcohol-related complaints. This ED was centralized in the community, offering easy access from a walking distance for most of the town. The hospital has 6 staffed ambulances and receives ambulances from private and volunteer crews around the state. Included participants were triaged for alcohol use disorder and then had to meet eligibility criteria. The project design required at least 154 participants, 77 pre- and 77 post-intervention, in order to have an adequate study power. Participants were not recruited because they were already in the emergency department for treatment of their alcohol use disorder. They were given a patient information sheet regarding the audit and SPURT tools, and they were able to participate or decline during the triage assessment. For the protection of human subjects, participants were identified by an assigned number. No confidential or identifying information was collected. Data was stored in a secure, locked box, and in 3 years, all data will be destroyed. And patients were able to opt out at any point in the study. The audit and SPURT were performed in a private room. The sample design was to select participants that included both the inclusion and exclusion criteria. They needed to be met before a patient was allowed to be in the study. Inclusion criteria were that the patient was 18 years or older, the EMR had documentation of current or past disordered drinking, the participant was alert and oriented, the participant was a patient in the chosen ED, the participant agreed to answer audit questions, the participant was agreeable to a recovery clinic referral, and the participant was medically cleared for referral. Exclusion criteria for participants were that the participant was younger than 18 years old, the participant was currently experiencing respiratory symptoms, the participant was in active withdrawal, the participant was currently in an inpatient treatment program for alcohol use, the participant was currently suicidal, or the participant was conserved. A total of 140 pre-intervention and 157 post-intervention participants were included at the end of the data collection period. For data analysis, the IBM statistical package for the social sciences was used to perform a non-parametric chi-squared z test of 2 proportions. All data was translated into nominal data for the ease of analysis. The independent variable was the data collection time frame, and the dependent variable was whether or not a referral was made. A frequency distribution was created to assess the nursing barriers to referral. A total of 297 total participants were included for a strong statistical power of 0.99. Pre-intervention referral rates were N equals 25 participants, or proportion of 0.178, and post-intervention referral rates were N equals 76 participants, or proportion of 0.484. The z-test of two proportions had a 95% region of acceptance, which was negative 1.96 to 1.96, with a z-score of 5.5478, suggesting a statistically significant change in referral rates from pre to post intervention. Emergency department nursing barriers were found to be 18%, N equals 9 participants said it was too much work. 40%, or N equals 19 participants, it does not help them. 0%, or N equals 0, said the referral is the provider's job. 4%, N equals 2 participants, said the patient refused. 4%, or N equals 2 participants, said they were not sure. And 33%, or N equals 16 participants, said it was situational drinking, or the nurse was unaware that an online referral could be made. The audit and SPURT referral process were successfully integrated to improve treatment referral rates. This screening and referral process filled a practice gap at the chosen facility where there were no existing process or protocol for referring this population. There was a statistically significant improvement in referral rates using the referral process compared to having no process at all. The post-intervention data is less variable than the pre-intervention data, revealing a higher consistency and increased likelihood of predictability. The barrier data can be used to improve the referral process education or to conduct future studies on barrier prevention. The audit and SPURT referral process prove effective in overcoming barriers to referral and increasing treatment referral rates when compared to having no referral process at all. Evidence shows that the referral process and its integration into nursing workflow mitigates the nursing barriers reported in this study. Improving treatment referral rates for the alcohol use disorder population in the emergency department is not only attainable, but imperative in the provision of quality, safety, and continuity in transitional care. The meticulous and extensive data collection efforts reduced bias and amplified the validity and reliability of the results. The referral process allows healthcare professionals to customize interventions in line with the patient's lifestyle to create a more impactful referral. With patients who were successfully referred, the ED was informally able to save money, resources, and time in reducing repeat visits. There are several implications for practice that come out of this project. Emergency departments are an underutilized critical access point for alcohol use disorder population. They would benefit from standardized referral practices because they create consistency, increase compliance, and reduce gaps in care continuity. Common nursing barriers to referral can be mitigated with a standardized referral process integrated into the nursing workflow. Eliminating inconsistencies in patient education with a standardized referral process helps improve patients' understanding of their alcohol use and their compliance with their own care. The solution is to develop a policy instituting a standardized treatment referral process for alcohol use disorder patients in the emergency department to identify early, educate specifically, and refer consistently. There are also several questions that were revealed through this project that offer insight for future research that can be completed. The first, what is the association between increased referral rates and reduced recidivism in the emergency department? The second, what is the post-referral recidivism rates, financial impact on healthcare systems, and do referrals resulting in sobriety time reduce cost strain and resource wasting? The third, over time, does the audit and SPURT referral process reduce implicit bias and staff frustration by creating a collaborative relationship between nurses and patients? And the fourth, what are the nursing versus patient expectations with regard to the referral process, and how do they differ from reality? Do they have a negative impact on referral success or barrier reduction? Overall, this project has found that alcohol use disorder has a damaging effect on public health, and patients who struggle with alcohol use disorder are often stigmatized and underprioritized. This research project found that the audit and SPIRT referral process significantly increased referral rates with a less than 1% error. Nursing barriers to referral were mitigated through the design of this referral process, and it fits seamlessly into nursing workflow. The outcomes of this research highlight a need for standardized referral processes in the emergency department and their position as a critical access point for the alcohol use disorder population. And implications for future practice and research pose the opportunity to improve the quality of patient care, reduce staff frustration, and decrease recidivism and cost strain. If there are any questions regarding the project or the presentation, I'd like to answer them now. But I'd also like to thank you for listening.